One and all, I would like to thank Dr. Divya ma'am for making me part of this IC. I will start with my refraction in pediatric population. As you all know, the pediatric population requires a regular assessment of their vision and ocular examination due to their unique visual needs. Different types of people will be coming to our OPD for different sets of checkup as for a part of normal checkup or for sibling screening as part of referral or detected defective vision or as a special child. Any patient who is coming to OPD, the two questions are very important. The parents will be asking, is my child vision okay? Can my child see? Or the next will be, do my child need glasses? There will be a tug of war between these two questions and we need to answer it properly. Can my child see is a very difficult question to answer. For that we need to go through the development of vision and also we need to do a proper refraction in pediatric population that should be very fast and accurate. Sometimes our refraction room will be quite as first picture or will be like the second picture. Timing of refraction at least before going to school and the children who are symptomatic need early intervention. And the refraction will be like a stepwise algorithmic pattern in adults and older children. But for younger one, it should be a tailored pattern and we need to use different type of pediatric charts. Cycloplegic refraction is a must and additional test including full thorough ocular examination is needed. So pearl number 1 is a detailed history, thorough examination and complete cycloplegic refraction is must for pediatric refraction. When and whether to prescribe the glasses is the next important question. Now we completed the cycloplegic refraction. We are having the retinoscopic reading and the refractive acceptance. So when we tell the parents that your child need glass, the questions will be, they will be bombarding questions like, really my child need glass or can wait doctor? How long my child need to use glasses? Is this refractive error will get corrected with glasses? Or is there any other treatment, alternative treatment other than glass? And the next other question will be, why my child's power is progressing even with glass? All these questions we need to answer. For that, we need to go through emmetropization and different type of refractive errors based on age-wise approach that we will discuss based on some cases. See, a 10-year-old child with compliance of defective vision came to OPD on examination. Uncorrected visual acuity was 6/18, improving to 6/6 with minus 2.5 diopter sphere. Rest ocular examination was normal. On cycloplegic refraction, it was minus 2.5 diopter sphere. So there is no doubt we need to prescribe the glass. But the most important thing in this child is 10-year-old in a progressive myopic age group. So we need to prescribe glass, also educate them regarding progressive myopia and environmental factors of progressive myopia. Also ensure follow-up, and if there is progression, we need to go for progressive myopia treatment. Coming to another 1.5-year-old child who came for ROP screening. Vision was mild myopic. Do we need to prescribe glass? No, we can wait. But we need to explain the parents regarding the refractive error and ensure regular follow-up. Same age child for ROP follow-up, but here the myopic reading was high myopic. So definitely we need glasses. Don't hesitate. We need to prescribe glass. Regular follow-up should be ensured. So pearl number 2, we need to prescribe glasses, explain the reason. Also, we need to explain chances of progression and we need to ensure the follow-up. And also teach the parents method to halt myopic progression. Another 2-year-old child with compliance of squinting. On evaluation, it was right XT, alternating XT, but left eye was dominant. Cycloplegic refraction revealed high myopic reading. Here, the thing is we need to prescribe full correction. Another 13-year-old child was referred to me for treatment of amblyopia. She was using glass for last 5 years, but the BCVA in the right eye was only CF 5 meter. Why it is amblyopic? Because she was unilateral high myopic. She was given a undercorrected glass in the right eye. So we need to prescribe full correction. Pearl number 3 is, do not hesitate to prescribe full myopic correction, especially in high myopes or in unilateral high refractive errors. Coming to a 12-year-old girl with compliance of defective vision, uncorrected visual acuity was C of 3 meter, improving to 6.6 with -7 diopter. On dilated cycloplegic refraction, turn out to be normal refraction. This is a case of pseudomyopia. So my pearl number 4 is any form of refractive error, do a proper cycloplegic refraction before prescribing glasses, especially in first time, if there is progression of power, change of axis or any associated eye strain with glasses. Coming to few hypermetropic cases, a 3-year-old child with squinting for few months, there is alternate esotropia. Cycloplegic refraction with atropine is a must, reveal high plus power. This is a case of accommodative esotropia, need full power glass prescription and also amblyopic treatment. Another 10-year-old girl noticed defective vision during school screening. Uncorrected visual acuity was 6/24, improving to 6.9 in right eye and 6.18 in the left eye. It is a unilateral high hypermetropia. She needs full correction in the left eye and amblyopic therapy also. Pearl number 5. Hypermetropic refractive error should be prescribed considering the best corrected visual acuity, squinting and amblyopia. Pearl number 6. Don't hesitate to reduce hypermetropic power after 8 to 10 years of age in orthophoric children and also accommodative esotropes in correlation with their BCVA and squint. A 3-year-old child with Down syndrome for ocular evaluation, dry retinoscopy was normal, but their dynamic retinoscopy revealed poor accommodation. Cycloplegic refraction also normal, but due to poor accommodation, we can prescribe a plus power. So, pearl number 7, not only refractive error, but also other factors like issues of accommodation, convergence, that lead to eye strain or asthenopia, and defective near vision should also be considered while prescribing glasses. Coming to few astigmatic cases, a 6-year-old child came with blurring of vision with full cylindrical power. She was not improving to 612. Here the confusion will be whether to prescribe full power or not. Definitely it is a case of meridional amblyopia. It will improve only with full cylindrical power. And another 4-year-old child came to OPD for treatment of injury with it is a case of hyphema, but on refraction there is a cylindrical power. She need to be evaluated after her acute state is okay. So pearl number 8, if there is any refractive error which is associated with amblyopia or significant for age related visual needs, or is there is an effect on strabismus, we need to prescribe the glasses even if there is no subjective response. And pearl number 9, special attention to be given to amblyogenic risk factors, anisometropic risk factors, aphakia, pseudophakia and subluxated lens. Also special situations like nystagmus, cortical visual impairment, syndromic children, autistic or hyperactive and neurological issue to be considered. A 12-year-old girl was referred for treatment of defective vision. Uncorrected visual acuity was 6/60 and counting fingers 4 meters, not improving. And the reason was large amplitude rotatory nystagmus, cycloplegic refraction was normal. So here we need to manage with low vision device, and we need to explain it is not related to the refractive error, the cause is the nystagmus. Another 8-year-old child referred for treatment of defective vision. The child was a preterm long neonatal ICU and vision was not improving beyond 612. There is no refractive error, but a fundus minimal pallor. There was extensive PVL changes was there. Here we need to manage the cortical visual impairment, vision therapy, addictive devices or low vision device is the treatment. Another 7-year-old was referred for treatment of defective vision. The child was autistic. Also, he underwent treatment for large arachnoid cyst. Here, the vision was not improving beyond 6/24. Fundus pallor and also large amplitude nystagmus was there. MRI, extensive encapsulomyelitic changes. On cycloplegic reading, there is a minimal cylindrical power is there. Here also we need to prescribe minimal cylindrical power, ensure follow-up and vision therapy and addictive devices or low vision devices the other management. So pearl number 10, low vision device, vision therapy and developmental therapy should be considered in required cases along with the refractive error correction. These are all the general guidelines. We need to be individualized based on case-based treatment, and follow-up should be ensured. So, spectacle prescribing is an art. considering the refractive status and visual acuity along with the global evaluation of child. Thank you.
Thank you, Dr. Chaithanya. That was a very comprehensive